This conference will now be recorded.
Okay. Hi, welcome everyone. I'm really glad you guys could all join us for our first virtual educational programming. We have Dr. Jeffrey Greenfield here today. So I'm just going to quickly introduce him. Dr. Greenfield is board certified neurosurgeon specializing in pediatric neurosurgery, but he also sees adults. He is at Weill Cornell Brain and Spine Center. He is the creator and director of the Chiari Care program, which I believe we're going to talk about a little bit today. And he is internationally renowned for his work with patients who are suffering from Chiari, Syringomyelia, tethered cord, a lot of the different issues that we're going to really talk about today. So with that, I'm going to just briefly send it over to Dr. Greenfield to introduce himself if you would like, and we can get started.
You're gonna introduce yourself?
Okay. Well, hi, I'm Caitlin Esposito. I work for the Bobby Jones Chiari and Syringomyelia Foundation. I'm pretty involved in a lot of the research programming that we're getting underway, which I hope we can talk a little bit about because Dr. Greenfield's been on the calls. So we can talk a little bit about that. But if anyone ever has any questions, you can find my email address on the website. I don't know if Mary or Dorothy want to introduce themselves, if anyone else is online that would want to, but we can get started otherwise.
Those of you who have found this through Bobby Jones CSF, you already know about their organization and their recent rebranding, renaming. But I really encourage all of you to spend some time going through the website. It's been beautifully redesigned and literally has hours and hours of videos from amazing surgeons, neurologists, internal medicine doctors, pain management doctors. I mean, it's an amazing resource for people who are looking for information, looking for people that are in their part of the country. Clearly, video has made it for us to all connect in a way that we didn't think possible just a short while ago, but it's also really nice to be able to see people near you. So we'll talk a little bit about what that all means for the future of neurosurgery, hopefully at some point tonight. I do want to thank Caitlin, Mary, and Dorothy. I mean, their organization has single-handedly brought a number of important initiatives and clear direction to the world of Chiari that didn't exist 10 years ago. And she was alluding to a new initiative led by some of the board members at the CSF organization that are truly looking at a new way of analyzing patients so that we can better predict who's going to be a good candidate for surgery. How do we advocate for our patients? Which type of surgery they should have? How do we follow them? And creating some standardization so that so much of the frustration that we hear from patients might be minimized in terms of the variability in what you're hearing for evaluation, surgical goals, who's a good candidate, what kind of surgery to do. And so hopefully we can create some standardization in a way that many other fields have done in neurosurgery. And Chiari has always been a little bit of a hard field to characterize because it falls in between so many areas, pediatrics and pain management, and CSF disorders and spinal disorders. And so no one's really ever taken the hold. And now that there are a number of people around the country who have really made it their focus and their initiative and come together, I think you're going to see a tremendous amount of research and data coming out. And I'm going to highlight some of that today, not my own. Some of it I'll talk about my own, but hopefully data that's coming out from a lot of the consortiums and collaborations that are just years old and will bear fruit for years to come. So thanks to the CSF, I think you really can't say enough great things about their organization. With respect to tonight, I think that Caitlin and I just brainstormed that this might be a nice way to connect people during a really trying time in everyone's lives, and we're all adapting to a new mode of medicine. And I've been seeing patients remotely, and I can talk a little bit about what coronavirus and COVID has been like in New York City at the epicenter if anyone's interested or is curious. but I think that this was something that we just said, let's just see if there's interest in it. We can certainly never answer everybody's questions in 60 minutes. And so, you know, what I think Caitlin and Mary will do later is hopefully follow up with everyone and see if there's some consensus in terms of what topics they'd like to get covered or didn't get covered, and we can maybe dedicate specific future sessions to more narrow aims. And then hopefully I can convince some of my partners in crime around the country, other folks on the board who you guys know so well, to contribute as well and do some similar seminars, since you know the diversity of voices are what makes this organization strong. It's certainly not any single person. So with that, I'm going to let Caitlin run this a little bit and maybe offer up some questions to me. I've seen all of the questions that have been submitted. I may take the liberty of kind of combining some of them and overlapping them to try and get as many people's questions answered if I can. And if I don't get to your question, I apologize. It may be because it's really complicated and difficult and may not fit in this forum. It may be because it's too personal, and it might be better just for us to have a conversation, and Caitlin or Mary can get you my email or figure out how to get in contact with me if it's something that really does need it. Some of you wrote in some pretty specific questions that probably should just be addressed between doctor and patient. So with that, thank you very much for coming, and thank you, Caitlin, and I guess we can get going.
Okay. I will add to that we absolutely do plan on doing this again. So if your question is not answered and it's not that it was too personal and better handled person to person, we will do this again. So definitely stay tuned for that. I think I'm going to start with kind of how you introduced everything with as far as how COVID is affecting Chiari patients, because I know we've gotten a lot of questions from concerned family members, parents. Is there any way that Chiari patients are more susceptible to this pandemic or are at more risk? Is there any way you can speak to that?
Yeah, it's a tricky question, but I think it's worth talking about. I mean, everybody here both has a connection to Chiari and has been affected by COVID, so I think it's probably worth talking about. So New York City essentially shut down on March 15th, and all surgical, and outpatient activities essentially stopped on a dime. It was really unprecedented in terms of the response that we prepared for and generated. And I can't speak highly enough about how all the hospitals in New York City and now, unfortunately, in other areas around the country have been responding to it. It's really been dramatic. I felt a little bit left out, to be honest. My skill set as a neurosurgeon was particularly useless in terms of taking care of patients with respiratory problems and lung issues and ventilators. So we've been taking care of a lot of research and catching up on a ton of writing of papers and collaborating with people. So it's been wonderful for us, but I've missed taking care of patients for sure. We've started doing video visits in the absence of face-to-face time. And I think that this has been a bit of a revelation for us in terms of how well it's worked. So much of what I do in my consultations with my patients, as many of you know, is talk. And, it is nice to have a neurologic exam and it's nice to be face-to-face, but sometimes it's just catching up, it's discussing symptoms. And for patients who are around the country, patients who feel vulnerable about traveling at this time, people who have difficulty traveling, who have difficulty coming to New York City or other major cities where a lot of the Chiari physicians happen to be located, this can provide a really nice conduit to get some information, create contact, and then decide on follow-up. In terms of how it's impacted Chiari patients, I think it's maybe in ways that we may not have anticipated. As we've been coming back online and we've been slowly ramping up operations again, in a literal and figurative sense, Chiari patients have gotten a little bit left behind because they often get viewed as sort of elective chronic patients, and we've been focusing on high acuity patients. And it's a hard battle to fight at the administrative levels, but patients who have ruptured brain aneurysms or brain tumors or spinal cord compression are now getting operated on fairly regularly and trying to triage a limited number of operating rooms and resources and PPE has been the trick. And so we're slowly coming online, and we're doing the best we can. But I think I didn't anticipate that the effect would necessarily be that we'd be putting off so many surgeries and seeing patients because of this. It's largely because of how the medical community views Chiari in a sense. And in terms of specifics on how this may affect patients who have Chiari, I think in terms of some of the comorbid conditions that affect so many of you, I think that the overlaps that I see are that in patients who may be susceptible, immunocompromised, who might have issues with some of these overlapping things like mast cell disorder, patients who are on chronic steroids, patients who are on chronic medications for IIH, patients who have implantable devices. I think we sometimes underestimate how fragile some of you may be. We, meaning the medical community, and I think it's both been challenging to figure out how to take care of you, but also reassuring to know that we have all these options and alternatives with video consultations. So in terms of my own practice, just so you guys know, since so many of you look like familiar faces, it's a good time to announce that we're now officially collaborating with Columbia University. So Cornell and Columbia, which are both under New York Presbyterian Hospital, it's actually now one pediatric neurosurgery service, and we're operating at Children's Hospital Uptown and at Cornell University downtown. So the adults will probably be mostly at Cornell, and a lot of the kids will be uptown because they're opening a little bit sooner. And this is going to essentially create a really nice, large collaborative group of highly talented partners of mine now. So that'll be really nice and give a lot of options and alternatives as things roll out in New York City more slowly than other parts of the country. So I'll leave it at that. I don't think I want to comment too much in terms of specific cases. There are people who have immune deficiency and other types of issues that I think are really addressed best one-on-one with your doctors. But clearly, we take these things into account when we're deciding timing of surgery and effects of travel.
Absolutely. Yeah, and there's obviously so much we don't know about the viral infection itself. So it's hard to make any kind of statement that if we just don't know. But go ahead.
For you guys, in terms of, I know there's been a lot of concern about what the hospitals are like, and what does it mean to go into the hospital, and if you have to have surgery. And I'll just say that I've been completely reassured and comforted being in the hospital and in the operating rooms the last few weeks. Particularly the Children's Hospital, there is no more coronavirus or COVID, and some of the post-infectious issues that you might have heard about in the news are all in patients who had infections weeks or months ago and are not infectious anymore, and they're all doing quite well. So the ORs are operating fairly normally. It feels like a normal hospital. It's just a little bit quiet, and there's a little bit of decreased flow. We're trying to keep visitors to a minimum. We're trying to keep extra people. There are no medical students hanging around, no vendors hanging around. So it's just a little bit calmer and quieter. In that sense, it's actually been nice. But we haven't really seen any effect in terms of quality of care, and there's certainly been no transmission between patients. So if there's any concern about that, I hope I can allay those fears that if you're ready and you need to have it anywhere in the country, as long as they're following CDC and WHO guidelines, as most hospitals are, you should be completely safe. So just wanted to put that out.
To piggyback off something you said earlier about joining up with Columbia, I know there are a lot of patients that travel when they have Chiari malformation to see specialists. So if someone was, say, further away or even on the other side of the country, how would they be able to interact with your institution specifically, understanding that there might be differences site to site?
Yeah, I have to say, Caitlin, that this has really evolved over the past 2 months, and I think it's been maybe one of the silver linings of COVID that we've been figuring out how to deal with the distance, and the lack of social interaction has been, initially I thought it was going to be really devastating, but I think it's been really nice because it's opened up all these opportunities to create video consultations and start conversations that might have been more difficult to do in the past. And so now we can essentially say, if you're interested in seeing patients, and again, I'll speak for myself, but I don't think this is different for anyone around the country. I know everyone on the board fairly well, and if you connect with people's offices, they pretty much want some basic level of background information. They'd like to see at least your original scans and your most recent scans, any operative reports if you've had surgery before, and then usually some other medical notes, whether it's from an ophthalmologist or neurologist or urologist, depending on what issues you're having. And then with that information, it's pretty easy to get a video consult organized. Doing them, now instead of having office hours once a week, I'll do 2 or 3 video visits every day. And so it's a little bit more flexible, it's a little bit more malleable. And I think we actually are more productive in these forums. So hopefully this will create an opportunity for things to improve in that regard. New York City is a difficult place to travel to, it's expensive. Now there's fears about traveling because of the infectious issues, and even if they're unfounded, I think it'll create a nice way to connect other patients with me and some of you guys with doctors in your area that maybe you thought maybe were out of reach or not accessible. They're more accessible than you might think.
Yeah, that's very true. I've been hearing that as well. So I'm going to pivot and ask a question that's actually come up in the chat a couple of times, and we had it earlier if you condense all the other questions. There's some research being done as far as how Chiari, even if mild, might cause cognitive symptoms, speech issues, coordination, but it's not well researched. Is there any way that you can speak to the potential connections and how maybe we can look into this in the future as far as treatment of those really bothersome symptoms might be for some patients?
Yeah, I can't tell you how interesting this topic is. I think that everyone on the board is interested in it, and it's maybe a little bit of a obtuse connection, but the fact that Chiari patients have cognitive difficulties is 100% certain in my mind. And if anyone tells you that they're not connected, I just think that they haven't done enough research or thought deeply enough about the question, because I may have been skeptical early in my career, and the more patients I've taken care of and the more people that I've seen improve in that regard, the more convinced I've been. One of the reasons why it's been controversial is because I think there's always been a concern that cognitive dysfunction or slowness, whether it's difficulties in memory or spatial relations or speech, may be related to the fact that Chiari patients are chronically in pain, and chronic pain patients all have some comorbid associations with depression and anxiety. And I think that that's not untrue. I don't think that that's necessarily an untrue statement that people who have chronic pain, like patients who have chronic diseases of any sort, cancer, autoimmune, rheumatologic, orthopedic, chronic symptoms do create levels of anxiety and depression that we don't see in the general population. So I don't think those two things don't necessarily go hand in hand. They do, but at the same time, the more research that has been done, the more obvious it has become that the cerebellum and the areas of the brainstem that the cerebellum linked to are connected to higher cognitive functioning areas. And there's a real link between what everyone thinks is going on and what it really is going on. We have an IRB at Weill Cornell that is looking at cognitive effects of Chiari in terms of doing neuropsychological testing before and after surgery. We have a specific battery of tests, a 30-minute test that we've created that is specific to looking at the types of cognitive dysfunction that we believe are common in Chiari patients. One of the drawbacks of this has been that insurance companies don't seem very interested in paying for it. Just, to be blunt, they don't think it makes a difference, and that may be true in part in terms of making the decision for surgery, but we're never going to move the needle forward and really find out whether or not we're onto something here or not unless we study it. And so we need to do formal testing before and after surgeries. and then in patients, control patients who have not had surgeries, to see if there's a real effect of surgery on those cognitive functions. If I can share my screen, am I allowed to? I'm in charge of it right now?
You should be able to give it a shot.
Here. Can you see this?
No,
No,
hold on one second. Let me just make sure.
Give me the option of
Oops. Let me try it one more time. Here we go.
worked before. There we go.
Now try. Okay.
Great. So you can see that now, I assume.
Yes.
Okay, so
yes, we can.
This is actually, I didn't plant this question at all, but this is a paper that just got published this month by two neuropsychologists in my group, Ken Perrine and one of his graduate students, Stephanie, looking at the neuroanatomic correlates of why there are neuropsychological problems in Chiari patients. We're certainly not the first group to be interested in this question, but Dr. Perrine is a really interesting guy who's interested in the connections between the cerebellum and the cortex. And so here are some pictures, and you guys I can share this around with you after the talk, looking at the robust connections between the cerebellum and the brainstem and higher cognitive functioning areas, prefrontal cortex, motor cortex, SMA, even speech areas. And so, basic neuroanatomy that's been known for 100 years has largely been ignored by surgeons and doctors taking care of Chiari patients, saying, no, there's no way that these things can be linked. And yet, real basic neuroanatomy shows that not only are they linked, they're really important. In kids that I take care of who have brain tumors in the posterior fossa, in the cerebellum, we know that sometimes doing surgery in this area of the brain causes something called cerebellar mutism, which is inability to speak. And for most of you who know anything about basic neuroanatomy, it's thought that most of the speech centers are actually on the left side of the brain if you're right-handed, some in the temporal lobe and the parietal lobe. These areas seem like they're a mile away from the cerebellum, and yet when we do surgery in the cerebellum, sometimes speech is affected. And so we know this, and we know what this anatomy is, and yet it gets ignored. And so all I can say is I'm very hopeful that there are a number of people, there are groups at Stanford, Jerry Grant is interested in this. In Rhode Island, Dr. Klinge is interested in this. Dr. Luciano and Johns Hopkins is interested in this. And hopefully we can move the needle forward on it a little bit, but it needs some rigorous testing and some collaborative efforts to really get to the bottom of it. But I'll just say, to finish this area of discussion, please push hard for your doctors to get you the testing you need. If you feel like there's a cognitive issue, don't feel like you shouldn't continue to push until you get the answers that you want to get, and that would be neuropsych testing at a center that's familiar with it. And I think you'll reap rewards from that, because you'll get real clear data on what's going on, and often the back end of it is cognitive remediation, where you can actually find tools and techniques to help improve. And so if you're not a surgical candidate, or you've had surgery and you haven't fully improved, there are ways to continue to improve those aspects of how those connections work. So it's a really great question and a really interesting field right now.
That's great. So again, I'm just going to keep choosing questions that kind of, oh, sure. I don't really have anything to.
It's just me? Okay. Leave that up there.
Yeah, it's just you. It's fine. So I'm going to keep piggybacking off of these other questions. So there was a question that came in asking what type of testing you recommend be done. I know there are a lot of comorbidities that can cause different symptoms that either correctly or incorrectly get attributed to the Chiari that may or may not get better after surgery. So what kind of testing do you recommend to diffuse out which symptoms are related to what, and whether or not they'll get better after surgery?
I'm going to pull up a talk here while I answer this question, because I think maybe some graphics here will help. So some of you have probably seen this classification scheme before, in terms of how I think about Chiari, and I think that there's probably no topic that brings up more controversy when I hear from patients about what other patients have told them, or what they've heard from chat rooms, or about what they need to get done to be tested. And I don't think there's a single answer here, Caitlin. I think that the important part of my evaluation is trying to figure out which lane the patients are in. And what I mean by that is that there's a very different workup that I consider to be essential for patients who have different parts of the Chiari spectrum. And so if you've seen this talk or been to my office or know how I think about Chiari, I think that Chiari is really a bunch of different diseases that all manifest with compression at the cervical medullary junction, right? So the brainstem and the cerebellum are affected in one way or another, and you may be born with it. It may be acquired over time. It may be due to instability. It may be due to hydrocephalus. There are so many different ways that the same type of symptoms might manifest. And for each of those patients, it's a little bit different in how I work them up. So I don't want to give the illusion that there is a single list of studies that everybody needs to get. I will say that the most common questions related to this is, do you need to get the whole spine imaged? And I'll say almost without fail, the answer is yes, not always. I'm going to say not always for everything, because I think there's an art to this, and I think it continually evolves, and I've changed probably over 10 years in how I've done this. So, if you have Chiari and you're diagnosed with Chiari, you definitely need to look for syrinx, and you need to look for tethered cord. Those are just so highly prevalent in those populations that I always start with those, and there are specific sequences that you need to do because they're often incomplete, and then you have to decide whether or not you're going to get more sequences done. I'm just going to plug in my computer because I see it getting low.
No problem.
Faster, right?
It's happening to me too.
And then, so after imaging the whole spine, then the questions are, what else is really necessary? For me, the only other really necessary part of the workup is almost always an ophthalmologic examination to look for signs of elevated pressure. And the reason why I've started doing that routinely on everyone is because I think that's the thing that is missed the most in adult Chiari patients. And it's the thing that creates the most complications if it's missed. So it's also really easy to do, and it's non-invasive. So the combination of being really important, helping avoid complications, and being non-invasive makes getting an ophthalmologic exam something that everyone should really do routinely if they've got Chiari, because it's the best way to non-invasively determine whether or not you have any signs of raised intracranial pressure. And if you've got raised intracranial pressure, whether it's due to hydrocephalus or it's due to IIH, right? So pseudotumor cerebri is known as idiopathic intracranial hypertension now. Those things really need to be treated well before the Chiari even gets looked at. And so, again, that my algorithm always looks at treating those things first. With respect to some of the trickier topics, I'm going to say that it's really much more on a case-by-case basis, because sometimes I don't need more information to make the diagnosis. Sometimes I do. And so testing for EDS, doing dynamic imaging of the neck, getting upright imaging, doing myelograms, getting neurodynamics. I can't say that I do that for every single patient, because A, it would be irresponsible, it would show a lack of focus, it would be incredibly expensive, and most of it would be negative. And so in patients where the silo, and again, just to spend a second here, since I'll probably refer to it a bunch here, compressive is the classic Chiari. Hydrodynamic is related to those patients who have CSF dynamic problems, hydrocephalus. Iatrogenic are those patients in whom something has been done to them and they've created a complication or a problem. That can be tethering, pseudomeningocele, cerebellar sag from large surgeries. Acquired Chiari from leaks, which has become more and more important, and I hope someone asks a question about that because it's become such an important part of my evaluations in my practice. Tethered cord, pseudotumor, and then the fun ones over here with the retroflexodontoid and instability, and these are the EDS patients. So you can see the evaluation algorithm is a little bit different for each patient, and even within these categories, I'll amend them or add things as necessary. So I'll just say that I think that if anyone tells you there's a one-size-fits-all approach to surgery or one-size-fits-all approach to the workup, then and they just haven't seen enough patients because the diversity of patients, the diversity of workups is really astounding. And I think it's something that's made this fun. It's made it interesting for me to think about and to write about. And so it may be a little bit of a non-answer, but I think get the full spine, get the ophtho, and I think almost everything else needs to be thought about in a really systematic way.
Yeah, actually, too, there have been several questions about basically pressure issues. So there are questions about, is it common for CSF to leak out of your nose or your ear? And then if there's eye pain, or obviously if the ophthalmologic testing comes back kind of abnormal, is there a chance that those individuals would lose their sight? So how do you treat something like that?
Yeah, that's a nice piggyback. You're right. I mean, it just sort of flows out from this hydrodynamic, and so maybe I can, if I go to the next slide here. So in the hydrodynamic pathology here, these are patients who have hydrocephalus or who have syrinxes due to hydrocephalus. I think that the problem has to be sort of traced upstream. And what I mean by that is, I'll show a really cool example here that I think I posted on my Facebook page earlier this winter of a young lady who had a huge syrinx, and turns out that the patient's syrinx was from secondary Chiari, and the secondary Chiari was caused by a primary CSF leak in the spine. And so the wrong thing would have been to shunt the syrinx or decompress the Chiari. And I think that may have been done in many, many places around the country. And for her, luckily, she complained of some really classic symptoms of CSF leak, positional headaches that resolved when she lay down and got worse when she stood up. And so even we don't do it very often, we did a myelogram because the CSF leak story sounded so convincing. And in fact, she had a leak, and all we needed to do was fix the leak. It was really difficult to find, and you need really, really talented interventional radiologists who know how to do myelograms with really specific techniques. So it's not something you can do everywhere. But once it was identified, the surgery to fix the leak was relatively minor. It was a small laminectomy, fixed the leak. That in turn allowed the cerebellum to ascend back into the brain because it was no longer being pulled down. And as a result of the Chiari being restored, the syrinx went away. So everything was the result of one small leak in the dura, in the lumbar spine, in the thoracic spine. But I could see and do see the sort of difficulty in, number one, finding that, diagnosing it. And I just know in my heart that there are so many patients out there with Chiari who have really small CSF leaks that we just can't find. And it's tragic, and it's hard to know what to do in those situations. But getting decompressed in that scenario will create worsening of symptoms. And, you know, we see it all the time. Caitlin knows that this is one of the biggest problems, are failed Chiaris. And it's not so much a failure of the surgery, it's a failure of the diagnosis. And, you know, if you don't think about the pathophysiology from the root cause, you can get into trouble. And we all do it despite trying our darndest to find out the root cause. Sometimes we just don't see it, or it's not there at the time. So, you know, just to make the scenario even more complicated, just imagine, you know, I was right about all that, and I was so smart, like, oh, great, we figured out it's a CSF leak, and then we don't see the leak because the leak closed by the time we did the myelogram. Sometimes that happens. And so now you're like, well, there's no leak. There's definitely not a problem here. Let's do the Chiari decompression, or let's take care of the syrinx. And so sometimes it's not for lack of trying, but because it's a really difficult problem. And so when you have things that come and go, whether it's pseudotumor, whether it's CSF leaks, it creates an even bigger challenge. And sometimes, despite our best efforts, it doesn't reveal itself the way we want it, and the wrong thing gets done. And that's just part of this field.
One of the follow-up questions that came up in the chat is it possible to have a normal ophthalmologic exam, but it turns out that there was a leak, and if there is a leak, how long is it possible for someone to have a sustained leak without having serious issues?
Well, so there are a bunch of really interesting things that question raises. So patients with really bad CSF leaks, if any of you know them or suffer from them, my heart goes out to you because it's really incapacitating. So patients with really bad CSF leaks really just can't live their lives. They can't stand up for more than 15 or 20 minutes, and it's truly incapacitating in so many ways. The question about the normal eye exam is really fascinating, and I suspect this is a patient who is experiencing this conundrum, because say that unless you really see tons of patients, it might not occur to you, but you certainly can have a situation where you have no papilledema or no findings on the ophthalmologic exam, and you might have periods of high pressure. And these are patients in whom high pressure is actually followed by periods of low pressure. And my ophthalmologist that I work with, Dr. Dinkin, he and I very closely follow a dozen or so of these patients who have what we think is like a cyclic ICP syndrome, where pressures are quite high at times. It causes enough of an erosion of the dura to create a leak. That leak then lowers the pressure, and depending on where in the cycle you happen to see the patient or do an LP or do a pressure monitor or do the eye exam, you might miss it. Papilledema sometimes is so profound that it will last long after the pressure is normal, and sometimes the ophthalmologist can detect that there's a history of papilledema, and that's really useful. But when I press all the ophthalmologists about the true number, they'll all say, yeah, it's not that common, but you can definitely have high ICP without papilledema. And so I suspect those are the patients who are getting lost here. In terms of how long you can have a leak for, I think that was part of the follow-up question as well. I think indefinitely. There are people who live with CSF leaks, and there are people who have multiple sources of CSF leaks. And so there are patients in whom every single nerve root has what we call a diverticular, or a little weak spot. And when we see myelograms and there are weak spots all over the spine, it can be really challenging to know what to do, because you can't obviously open up the entire spine and fix every single level. And so it creates a little bit of a whack-a-mole where you try to fix what's leaking at that time, and it could be 3 months later something else opens up and starts leaking once you fix one area. So the truth is it could be anywhere, and in those patients, the best thing we could do sometimes is lower the pressure with medications, sometimes with shunts, treat them symptomatically when possible, and if they do have a Chiari, sometimes it is necessary to do a decompression just to give them some room, because they may be symptomatic even if you know what the underlying cause is. So it's complicated for sure.
So just to kind of tie a bow on this conversation, because it's fascinating, but CSF leaks and different pressure disorders will definitely affect, or may affect your vision and symptoms related to that, correct? Just to make it clear.
Yeah, so there are a number of ways. So just to spend a minute on the vision question, since I think that was maybe I missed the tone of the question, but you can get visual symptoms in so many ways. So clearly in pseudotumor patients, in the classic elevated pressure scenario, the problem is pressure on the optic nerves, and that's blurry vision and visual loss. Patients with brainstem issues like craniocervical instability, a lot of EDS patients report to me that they have periods of blacking out or black floaters or difficulty focusing. I think those are really common. And then in patients who have CSF leaks, sometimes we'll actually see sagging of the brain and sag and pull on the cranial nerves. And so some of them will get sixth nerve palsies or fourth nerve palsies, which results in diplopia. That's either difficulty conjugating your gaze up and down and seeing double in a vertical orientation, or left and right and seeing double in a horizontal configuration. So it can really run the gamut from blurry vision to floaters to blackouts to difficulty coordinating your eyes. So you know, it can really go across all those spectrums there.
Yeah, I'm sure there are going to be a lot of follow-up questions about this,
And
but I do want to pivot. Oh,
I,
go ahead.
ophthalmologists are really key here. And, neuro-ophthalmology is an emerging field. And, I work with a group of fantastic neuro-ophthalmologists, and they are really invaluable to this diagnosis. And whether you've got pseudotumor or Chiari and you come to see me, you will see an ophthalmologist as part of it, because I think it's so integral to the diagnosis and workup. And they're really important. You can do that almost anywhere in the country as part of your workup. So I highly recommend that.
Yeah, they're your friend for sure. I feel terrible having to turn away from this conversation. I'm sure we're going to have to follow up with another one of these. But I do want to get to the issue of tethered cord, because a lot of people asked it, even in the chat just now. I saw it come up. Why is it, and I guess this kind of also dovetails into another question that we had, why is it that tethered cord is so often missed? How is it appropriately tested for? Is it a matter of radiology? Do we have to educate the neuroradiology community in some way? Or is there just not enough known about how it presents? Is there any way you could speak to that? And then I guess how it's treated, because at the end of the day, the detethering would be done by a surgeon.
Yeah, this has become one of my favorite areas of research. And again, I know it sounds like we're researching everything, but we actually are going to have a clinical trial opening up for occult tethered cord very soon, because I think it's, again, just like the neuropsych part of Chiari, occult tethered cord is this whole mysterious realm that so many doctors, radiologists, and neurologists either don't understand or don't believe in. And unfortunately, the word occult pinned on to this disorder has created some of that stigma, I think. I mean, I personally think of occult sounds, like witchcraft, and attaching witchcraft to, a medical diagnosis is a bad combination for, malpractice rates. So, I think there have been practitioners who have pushed the envelope and have done so in a responsible way, such that we've learned a lot of important information. But I think traditional neurosurgery, the community of neurosurgeons, has been very cautious about adopting it and moving forward too quickly. And I think that the radiologists and the neurologists are going to lag behind us. I think some of that, the controversy and some of the difficulty, just comes from the terminology. I think, if we could explain it better and describe it better, it would be much easier. And the way that I try to distinguish between tethered cord radiologically and tethered cord syndrome, I think, makes all the difference. If you ask someone if they have a tethered cord, what everyone's going to think you mean by that, if you're a neurologist, a neurosurgeon, or a radiologist, is, do you have signs of a fat infiltrated phylum terminale? Do you have something called a fatty phylum? Other types of tethered cord, from lipomeningoceles to Diagnostic, they can all cause tethering, and they all do. But those are really easy to see. The less obvious it is radiologically, the more difficult it becomes to make that diagnosis. And so if you have a normal appearing MRI scan, right, with appearing in italics or bold, then it's going to be twice as hard for you to get this diagnosis. And so what you have to pivot to is ask the question, not do I have tethered cord? The question is, do I have tethered cord syndrome? And tethered cord syndrome is really what makes it much more understandable and palatable for other doctors, because what you're talking about is a constellation of symptoms and signs that can't be otherwise explained by 7 different body groups being involved. So think about, the way I think about it is to sort of divide it into orthopedic issues, things like scoliosis and club foot, leg length discrepancies, hip dysplasias. Those are orthopedic issues that may be related to problems with the lower end, the distal part of the spinal cord. Then there are the neurologic issues, right? So it could be numbness, tingling, it could be weakness. I consider pain to be a neurologic issue. So low back pain and leg pain in the absence of any other explanation. Urologic symptoms are right at the center of tethered cord syndrome. So if you've got a neurogenic bladder, a bladder that is not receiving the proper inputs, that's not contracting properly, this is a diagnosis you can get from a urologist very clearly. That is really central to the tethered cord syndrome diagnosis. Other radiographic findings: do you have a syrinx or a terminal ventricle at the bottom of your spinal cord? Do you have any elements of your spinal canal that didn't close properly, dysraphism? Do you have skin abnormalities like hemangiomas or little tufts of hair or little dimples that might be clues? And I think putting all those together can create enough of an argument that there is some dysfunction embryologically that relates to the symptoms that the child or the adult is now experiencing as a constellation of signs and symptoms, not a radiographic diagnosis, but a medical diagnosis. You've got tethered cord syndrome. And so in those patients, I feel much more comfortable once they've reached the threshold, and we can talk about what that may or may not be. I think that's debatable. Then the decision as to whether or not you want to release the filum terminale, even if you can't see anything on the MRI scan, is where the neurosurgical decision making comes into play. And so I think that's a really tricky part of this field. Whether or not it's related to Chiari, I think is something that people are curious about, whether or not tethered cord release can improve Chiari symptoms. Definitely anecdotally, people talk about that. Radiographically, you don't see the brain spring back up, magically. That doesn't happen. It's just connected in two places with nerves and blood vessels, but you can get symptomatic relief. It is an important cause of syringomyelia, particularly in the lower thoracic and lumbar areas. So if you have a syrinx that's really low down in your spinal cord, not up in the cervical area, but way low down, that makes me think of tethered cord as well. So I think it's not a single answer, but rather a little bit of a medical kind of game of, you remember that TV show House? You're putting together all these pieces of information and trying to come up with a diagnosis. That's a little bit what it's like. And I just saw a boy today in the office who I've been suspicious of tethered cord for over a year, and we finally got urodynamics done that showed neurogenic bladder, and it was kind of like a aha moment. We're like, I think this is it. I think we have it. Normal MRI scan, lots of unexplained symptoms, and this was sort of the piece that we were missing. And it took a while to convince the family to get urologic studies done, but once we did, we're able to move forward now. And so no one's asking easy questions here. These are all really complicated. I'm not, getting off tangent too much, but I think that it does really highlight the complexity of this field and why it's important to think about this broadly and really focus in your diagnostic maneuvers based on what you're seeing, and not just sort of scattershot, patients the same types of testing across the board. Did I answer? Unfortunately, I'm not sure I answered.
I think you got to it. None of the questions are going to get easier. If that makes you feel terrible, I'm sorry. But so I guess the next question, we're going to kind of stay on the imaging issues here. Firstly, how common is Chiari 0? And I think that should just be a standalone question as far as knowing if it's common, whether or not that's something that needs to be surgically treated. What would you say?
So I don't want to get in trouble here, but I'm not a huge fan of that term. I'm a big believer that you can have Chiari symptoms and you can have syrinx in the absence of herniation. So I don't want to misrepresent how I feel about it. I think it's come to mean the wrong thing, and I think people have begun using it in the wrong way. Chiari 0 was initially described in a really small sample of patients. It was just an observation by really neurosurgeon that a bunch of patients who didn't meet the criteria for Chiari had syrinx, and they seemed to get better if you did Chiari surgery. And it doesn't really necessarily answer the question as to whether or not it's a specific or separate diagnosis. I think we've all become a lot more comfortable with the idea that you don't need to have 5 millimeters of herniation to have Chiari symptoms or to have enough blockage of CSF to get a syrinx. And so I think Chiari 0 really just means Chiari without a ton of herniation, and I think that will encompass most of it. I'm going to show one other thing here if I can. Let's see. Let me go to my, I'm still sharing here, right?
Yes.
Let's just see where this, oh, pressure. Well, maybe it's not there. Here it is, let's see. So this is a talk that I gave just recently at a neurosurgical meeting about something called Chiari 0.5, and I've given this talk before to the CSF group. And basically what it is that in patients who don't have a ton of herniation down the canal, it doesn't mean that you don't have a blockage of flow, because I think people often will focus so intently on that one mid-sagittal view of the MRI scan that everyone thinks of with Chiari, and they make the measurement and they see how low the tonsils are. This is a really important view that I think anyone who's interested in Chiari or is trying to get a diagnosis for themselves, really look at this for a second and focus, because this is a cross-section through the brainstem. And so the three-dimensional nature of the brainstem gets lost in those mid-sagittal or sideways views sometimes, because there's CSF that's flowing all around the outside of the brainstem, not just down the back. And so when your tonsils, represented by these kind of little red half moons here, wrap around and compress the sides of the brainstem, they can also block flow and actually compress a lot of these cranial nerves that are leaving out here. That can cause problems with swallowing, with breathing, sleep apnea, nausea, vomiting, things like that. And so here's just a picture of what this might look like. So in a patient who otherwise has, this is a normal MRI scan for comparison, who might otherwise not have a ton of herniation down the brainstem, down the foramen magnum into the spinal canal, this is a cerebellum that is wrapping around the side. So here's the brainstem, that little circle right here, and here's a cerebellum wrapping around the side here. And this is a little girl who actually had a G-tube and could not feed because of severe dysphagia and aspiration. Was decompressed and was told that they, no longer had any compression. And sure enough, on the mid-sagittal view, they look like they were decompressed. But when you look at the cross-sectional view, there's no way that the nerves that are leaving out the side of the brainstem here are not being completely compressed by the cerebellum here. So a very, very focal operation to decompress that was just highly, highly effective. And they came back 3 months after surgery, and she didn't have a G-tube anymore and had gained 20 pounds. It was pretty remarkable, and not every case works out that well, but I include this because it's such a poignant example of how sometimes one type of imaging can miss it. So to get back to the Chiari 0, I think there are a number of things that can cause syrinx in the setting of not a lot of herniation. One is this Chiari 0.5, where the tonsils are wrapped around the side. The other is something that's been talked a lot about in recent years, and that can be a really simple obstruction of CSF flow at the obex. The obex is a little opening at the very bottom of the fourth ventricle. Let me see if I have a picture here. So right at the very bottom of the fourth ventricle, I can't really see it here, there is a little opening, and that's the opening where the central canal, which is the little tube that runs the entire length of the spinal cord and turns into the syrinx. If you get a little focal blockage of the obex from a web of arachnoid or tissue or scarring or a little blood or any number of things, or an old infection, then you can get a really significant syrinx and obviously lots of Chiari symptoms in the absence of any type of Chiari herniation whatsoever. So I think that Chiari 0 is a real thing. I think it's been morphed a little bit to maybe represent something that it's not. But if you feel like you've got a syrinx that isn't otherwise explained, or Chiari symptoms that aren't otherwise explained, do a little bit more digging, look at the imaging on different planes. And sometimes you need to do an intraoperative exploration. And that comes back to the very thing that these authors down, it was from the University of Alabama, did. And they explored these patients and found that they had obstructions. And so it takes a lot of guts to define a field like that, like they did. But I think it also points to the role that patients have in continuing to push for answers if they don't feel like they're getting the answers that they want from their local doctors.
Yeah. That's good advice. I'm going to shift a little bit to very specific to your field. How often should patients get MRIs? So I know we had a question where a patient experienced that their syrinx got bigger or it even moved down or up their spine. And then there was also a question about whether or not growth in pediatrics more specifically would affect their Chiari or the developing or resolution of a syrinx. So how often do you recommend your patients get MRIs and a full cord or not? What would you say about, I guess, following these patients over time with or without surgery?
And then the growth question. The growth question is an interesting one, so remind me if I don't get to that. So the routine for following patients. So the way that I tend to do it is that I get an MRI scan 3 months after surgery, and I used to get an MRI scan at 1 year, and do that routinely on everybody. I'm a little bit more relaxed about that 1 year MRI scan now, particularly in kids where there may be some need for sedation or difficulty in getting them. And I've become a lot more confident in making sure that we understand the symptoms, educate the parents really well, and rely a lot more on the parents and the symptoms than we do the MRI scans. In general, 3 months and 1 year, and then after that, really symptom-based. So if you're well, and most of you guys know that kids tend to do well if they're not complex, and they tend to get done at a year, and then that's it. And if they come back, we get neuroimaging because they've got new symptoms. And we don't do routine imaging after a year if they're doing well. For patients that we follow, if you've got a Chiari and you have minimal symptoms and we decide that we're not going to do surgery and we're going to follow you, I don't do repeat imaging on any type of schedule that is dictated by the calendar. I'll get a full spine, and if there is a syrinx, then I will follow that. I will definitely get a repeat scan of the syrinx because whether or not it's correct or not, I think an enlarging syrinx to me is one of the few areas that makes me a little uncomfortable about watching too long. So I'd like to know if they're asymptomatic and they have a syrinx, I'd like to know if that thing's getting bigger or not, because that might push me over the edge a little bit, even if they're asymptomatic, but not always. For patients who have no syrinx and just a Chiari, I don't get repeat imaging. We decide how we're going to follow them. We're going to decide what the metrics are that are important to the family, keep track of their headaches, keep track of their symptoms, make sure they're hooked up with a neurologist or their pediatrician is educated, and then follow them clinically and get new imaging if they need it. Ophthalmologic exams are something that we can do routinely, getting other physicians involved, and really getting the kids to the age where they can begin to self-advocate, because I think the repeat imaging is most useful in some of the very populations where you don't want to do it. So young kids who can't tell you what their symptoms are, or can't self-advocate, or kids who have a really large syrinx. So in general, I've become more relaxed with imaging over time, but I also, I do think there's a role for surveillance, for peace of mind, and for management of syrinx, but it's not always necessary. In terms of the growth, it goes both ways. So I think that for any of you guys out there that have really little kids and have seen me, you know that it's a population that is really tricky to manage, because the reoperation rate in little babies with Chiari is really high, and that's because of a really simple fact that their skulls literally grow back because they're the factors in the dura that actually create bone are still active and creating bone, and the skull is changing. And so we try to buy time sometimes by doing a minimal decompression and get them to the point where the skull will actually start growing. And we will see kids actually outgrow Chiari symptoms if they've had them when they're infants. And we know that from the fact that sometimes they get symptoms back again. And when they come back to see me and they're 8 years old or 10 years old, and I ask them about the first 6 months of life, and I say, did you have trouble feeding your baby? Did they have trouble sleeping? It's invariably yes and yes. And so they probably had Chiari, and it was really bad when they were infants because it often is really tight. And then as the skull grows and there's more room, it becomes more relaxed. And that's not something I was trained to recognize or knew, but have observed numerous times. And so sometimes you can do that. It doesn't mean that they're going to outgrow it forever, but sometimes it means they can go many years and not need surgery. And surgery on really young babies is something that we try to avoid for many reasons, for anesthetic reasons, for blood loss reasons, and because the reoperation rate is higher. In terms of once the skull is grown, you know, there's not a whole lot that goes on, to be honest with you. People are often shocked to know how little difference there is between the size of a 3-year-old's head and an 8-year-old head or a 15-year-old head. Your brain really grows rapidly early in life, and the skull is big. If you know, you may not notice it, but if you sort of look around and you sort of see these toddlers running around, they look like lollipops, right? They got these big heads and little bodies. And so the difference between a 3-year-old's head and an adult's head is really not that much in terms of frank percentages. So not a lot goes on. There's not a whole lot of rationale for scanning patients throughout their lives. It's something that I don't really understand, that I see a whole lot. The patients who have changes in their tonsillar herniation, you know, patients who say, I had an MRI 10 years ago and now my herniation is 3 millimeters worse. There are two populations of patients who will make a statement like that. One are patients in whom the MRI scans are identical, but radiologists have read them differently on different slices and different sequences, and the difference between a couple of millimeters means absolutely nothing. But it will sometimes look to new patients or uneducated patients in this field that things are getting worse, and that's not necessarily the case. The brain actually moves every time the heart beats, and if you've seen any of these surgical videos, you know it can move 3 or 4 millimeters with every heartbeat. It literally goes up and down as the blood fills the brain and then empties out of the brain. So depending on where the MRI captures that image, it can actually look different. So a couple of millimeters is not real. If you have an MRI scan that shows that you had no herniation and now you've got 18 millimeters of herniation, that's not that the Chiari grew. That is not Chiari malformation. That's a CSF leak until proven otherwise, or pseudotumor cerebri, or hydrocephalus, or God forbid a brain tumor. That's something that's causing the tonsils to push down or to get pulled down. And in those patients, again, Chiari malformation surgery is the last thing that you want to do. You need to immediately call your neuroradiologist and say, I need a myelogram. I need to find where this patient's leaking from. So if you have a dramatic change in the size of your tonsillar herniation, it is not that your Chiari is growing. So I hope I sort of answered all parts of that question there.
You did. You actually answered a question that I didn't even ask about Chiari's getting worse over time in that way. So thank you. There are 3 questions. One came up in the chat, and there are 2 that I really wanted to get to that were asked before. So we're going to go over a little bit, and I apologize for that. But one of them is very, very pointed. It's what's the usual course for kids and who have Chiari and scoliosis? So a lot of the times they don't have typical Chiari symptoms, they just have the scoliosis. What would you do in the case of a pediatric patient with scoliosis and Chiari if they're trying to avoid surgery, which is usually the goal?
I have this ready here.
Great.
So, so the Park-Reeve Syringomyelia Research Consortium, this is an amazing group of surgeons around the country that have all agreed to share their data, and the topic of syrinx and scoliosis is a really interesting one, and it's a completely causal relationship. And so I work across the street from the Hospital for Special Surgery that is just does tons of scoliosis surgery on kids, and so we know from seeing all these patients that they now actually scan every child with scoliosis with an MRI scan. And that didn't happen, I think 10 years ago, even as recently as that was not the case. It was only if they had some neurologic symptoms. And it's now become clear that there's a huge link here. And the link is probably related to some type of problem with CSF flow. And so in patients who have the kind of the triumphant, they have Chiari and syrinx and scoliosis, it's very analogous to this kind of backwards rationale that I used before in terms of, well, the scoliosis is being caused by the syrinx because the syrinx is putting pressure on those nerves that are innervating the rib cage and the muscles, the paraxial muscles that support the spine. And if you have an imbalance there, you start to get a curve, and then the scoliosis is a correction of that. The scoliosis is caused by the syrinx, but the syrinx is caused by the Chiari. And so you got to go back up to the top. And so you can't do scoliosis surgery unless you actually fix the primary problem. And so this is a tough pill for a lot of parents to swallow, because you have to explain that, yeah, you actually need to have Chiari surgery first, but that doesn't mean that it's going to fix everything, and doesn't mean that you're going to avoid scoliosis surgery. And so the easiest way to think about this in terms of just an easy ratio is that about a third of patients will actually get better in terms of their scoliosis after the decompression surgery. About a third will stabilize, and a third will get worse despite having surgery done on the Chiari and syrinx. And so a good percentage of patients will still go on to need corrective surgery. But the good news is that no orthopedic surgeon who knows what they're doing will ever operate and fix a spine until the Chiari and syrinx has been addressed anyway. So either way, you need to have a neurosurgeon and an orthopedic surgeon working closely together and figure out the timing of those two interventions. This paper just came out literally like earlier this spring, I think, of this big consortium looking at the factors associated with the syrinx and how that impacts the scoliosis. And it's clear that there are factors that we can now predict a little bit more because of the great collaboration between all these surgeons, that the size of the syrinx, the age of the patient, all these things do have an important role in determining whether or not they're going to need to have surgery or not. And generally, young kids, big syrinx, those are the patients who tend to do worse, as you might imagine. So nothing earth-shattering, but at least scientifically proven that that link is there and it's real. And so hard to predict, but certainly something that has some science behind it.
That's great. So the question that came up in the chat, are TIA strokes something that might be caused by Chiari or some sort of brainstem or brain compression? And would a decompressive surgery help stop something like that, or even seizures? That was another question that had come up. Would a Chiari decompression help to correct those issues?
Well, the first one was what, stroke you said?
Sorry, TIA, so mini stroke.
Yeah, those are two really interesting questions that are obviously linked together. I would say that for the general consumption, vast majority of patients, I would say no. Are there examples where I think I can link the two together? Absolutely. I think I have anecdotal evidence of patients who have had compression of different parts of the vasculature in the posterior fossa. I published a paper 5 or 6 years ago about a woman in whom we actually opened up and did the decompression and found that one of the arteries was kind of aberrantly placed, and the bone had actually been compressing that artery for probably years and decades, and had actually caused an area of ischemia, meaning that area of the brain never got any blood flow. And so there wasn't evidence of a stroke directly related to it. I think in most cases, that's not what we find. Those are really severe, unique cases. And in patients where they're having TIA symptoms, meaning they're getting lightheaded or blackouts or faint dizziness type of things, and I imagine that's probably where this question has its origins, that's probably more related to dysautonomia, blood pressure, dysregulation, so having low blood pressure, having tachycardic syndrome. These are much more common and I think probably underreported in the Chiari population. I see them all the time. Clearly, they're really rampant in patients who have EDS and cranial cervical instability. But I think even in patients who don't have EDS, I've seen evidence of significant hemodynamic issues. And so there may be a component there. And that's an easy thing to sort out. Not easy, but doable. You can get a Holter monitor. You can get a Fitbit or a watch that has a heart rate monitor. You can actually monitor your symptoms, and your symptoms now are quite accessible with smart devices. So it might be something that you could either do on your own or with the help of a cardiologist to get to the bottom of that. The seizure question, I'm personally fascinated by. No one else in the world seems to be, so I'm curious who asked the question, and maybe we can have another conversation. I'm pretty sure that there are, just like there are connections in the cerebellum that are causing cognitive dysfunction in Chiari patients. I'm similarly intrigued by the idea that compression of the posterior fossa may also cause epileptogenic activity. And we don't ever see it because when we do EEGs and we measure for seizures, we put electrode leads on the top of the head. No one ever actually monitors the cerebellum. And so I've been curious and interested in potentially looking and monitoring some patients, looking at their electrical activity on their cerebellum, during surgery or before and after surgery, and seeing that. But I haven't pursued that, but I think it's likely that you'll hear some stuff about that in the next few years. But if you ask a neurologist or an epilepsy doctor if Chiari can cause seizures, they'll send you out of the room and slam the door in your face. So be careful.
Yes. So there's just two more questions. I promise. I hope they're not too complicated.
No
One
problem.
is really specific to recovering from surgery. So there was a patient who was 6 months out after decompression, and she or he, actually, I'm not sure, were still feeling weak and had a lot of pain in their neck and upper back. So they were curious, is this part of the healing process? Is this normal? Or should something be done 6 months out where you're still having these issues, or even 12?
Yeah, that's it's a little specific in terms of their own recovery, but I think that in general, I've found that there's a pretty huge spectrum of recovery scales, and I think as I became more accustomed to this variability, I became a little bit less rigid in my definition of what a normal recovery would be. People ask what a recovery would be. I usually still say 4 to 6 weeks, but I think that that's, until you can get back to some semblance of functioning. In terms of pain and recovery and full range of motion, or not needing to be on any pain medications or muscle relaxants, some patients take up to a year to recover. And so I think there's a huge variability there. I think the underlying question there may have been, is there something else going on? And I think that that's always a question. And, this question of failed Chiari surgery is something that still, intrigues me and, bothers me about my own patients. I see a ton of patients with failed Chiari from elsewhere, but I definitely have my own patients that have failed. And knowing when do you think it's enough time, that you've given it enough time and it's not going to get better? When do you think it's time to go back in and re-explore? When is it time to consider other etiologies that you might have missed, like craniocervical instability? Or did you miss a CSF leak? Or did you miss pseudotumor? Or did those things come up after surgery? So I can't say in general that there's a rule of thumb on that, except that some patients take a really long time. And if you're not getting better, or if you're getting worse in particular, then don't be shy about going back and saying, look, I don't think everything is right here. Is there anything else we can do to explore this? And it may not, be an easy road at that point, but certainly, try to find someone that will work with you to just try and sort through those problems. But it's definitely one of the trickiest things that we face in this field. So I feel for you right now, but give it some more time if you can. And if not, then go back to your surgeon and start going down that list of those conditions that we've talked about.
So a lot of this is back and forth with your clinician. And I mean, I wish there was an easier way to do it, but there's really not.
Yeah.
So the last question really has to do with the state of Chiari research as it is now. I know a lot of the questions that we had from patients that you answered, you showed papers that had been published not a couple of weeks even ago. What's going on in the Chiari and Syringomyelia related disorders research world? And is there anything that, I mean, obviously I know that there's stuff that we're doing to try to make it move a little faster, but how do you see this advancing over the next 5 or even 10 years?
Well, I think that, the paper that I have up here is, speaks to itself. I mean, you have surgeons from every single institution around the country almost represented here. So the fact that everyone is working together and are putting aside their kind of, individual, aspirations and goals and, desires to work as a team and collaborate is, it's pretty obvious just looking at that list of luminaries. So that's great to see. And I think that that's going to really push the field forward, because I think people recognize that publishing your own, 15 cases or 20 cases no longer cuts it for research in Chiari, which it used to 20 years ago. I think people are also becoming a lot more aware of a lot of these comorbid conditions that all the patients seem to know about, but none of the doctors seem to know about. And I think that that's going to eventually trickle down. What I've personally tried to do to move the needle, at least in my own neighborhood, is sort of work with the gatekeepers. And so I gave grand rounds to the entire Department of Neurology and gave them the look, and that's kind of going into the lion's den. A lot of neurologists don't think that surgery is the right thing for a lot of patients with Chiari, and so I kind of stood up there and and took arrows for a while. But I said, look, these are the things that have changed in the last 20 years. This is what we know. These are our outcomes. You need to diagnose this. You need to refer these patients. Just because you send a patient to a neurosurgeon doesn't mean they're going to end up with surgery. And I think that was always part of their fear. So, I'll just say what we're doing, I think, is working. Getting out to the community, educating patients and educating the gatekeepers, the neurologists, pain management doctors, to know about these conditions and provide the right referrals is ultimately going to be the goal. The one area where I feel like we're a little bit stuck is on radiology, and I'm not exactly sure that that's going to be as easy to infiltrate. They don't necessarily read our literature. They'll produce reports that don't even mention Chiari sometimes, and I've seen this so many times from patients, that the frustration of finding out 5 years later that their MRI scan done 5 years prior had actually a Chiari on it, and they were not told because it wasn't on the report. It's going to require a little bit even more level of infiltration, because there are so many independent radiologists who are working at radiology centers and freestanding businesses that have MRI machines. And so, and I'm not sure I have a great answer for how to do that, except that we've got to just keep trying to go out there and educate our colleagues in those fields to help move it forward. But ultimately, I think it's going to be you guys. I think patients are the ones who have moved this forward. Just for a maybe an inspirational close here. The other part of my life that's not done taking care of Chiari patients is taking care of kids with brain tumors, and I've been so similarly impressed with how the community of parents who have kids with brain tumors have self-mobilized to say, what, pharmaceutical companies aren't taking care of us, research isn't taking care of us, we're going to do it ourselves. And they raised money and started foundations and got research and have made tremendous strides in 20 years. And so sometimes it takes, the feeling of not being heard or not being taken as a serious group of patients to mobilize together and create enough of a voice so that the research does get done. And this is what the Park Reeves Initiative is. That's a family-run organization that put money behind this. And you guys who are giving money to CSF to run these forums are doing the same thing. So I think it's all moving in the right direction, and I've never seen better research or more robust rate of publication. And so as long as people are sharing and reading and implementing what we learn, the needle will move forward. If people stay stuck in their ways of doing things and aren't willing to think about occult tethered cord or think about EDS as a comorbidity or look for CSF leaks, then a lot of patients are going to get missed and potentially get hurt by having the wrong surgeries done. So I think we're heading in the right direction, but we're certainly not there yet, and that's why we need these forums. So I appreciate all you guys sharing all these great questions and being a part of this. And I think I'm happy to continue to be a part of this and to continue to try and provide information when I can, and similarly try and nudge some of my compatriots, many of them who are on this list here, to do similar forums. So I think you might hear variations on a theme and different approaches, and I think there's no single right answer to many of the questions that you asked today. So thank you.
Oh, thank you. I know we're definitely going to be reaching out to you to one of our programs that we're really trying to push, and I don't know if it's something we have to do after COVID-19, but we're trying to do some more grand rounds, and like you were saying when we started, maybe it's something we can do virtually. where
Right.
we would have someone like you go to another institution, give a grand rounds about why the radiology is really important. What we talked about with tethered cord, where it's not necessarily on the image, and
Yeah.
sometimes people get better. So, I mean, I know we're looking to do all that. So as long as you guys are in our camp, I think we're going to be good.
Awesome. Well, thank you very much, everyone. I guess there's no way to say goodbye to 100 people, but thanks for coming. And,
Thank you.
continue to share your
Thanks,
questions.
everyone.
Thank you so much, Dr. Greenfield.
Thank you.
Thank you.
Thank you, Dr.
Thank
Greenfield.
you.
It was a pleasure.
It was great. Thank you.
Everybody stay safe.
And stay tuned. We're going to be doing more of these.
Look forward to it.
We're already planning the next one.
Okay.
Thanks, everyone.
Take care. Enjoy your summer.
Thank you.